How are you doing? Beth is a nurse here at Hennis Care Center in Bolivar, Ohio, and she's the unit manager for a specialized unit we call it the Homestead Unit, and it's geared especially towards dealing with people with dementia. Beth, I have a couple questions for you. What is the benefit of having a specialized unit for dementia as opposed to just having the people out, among the general population here at the nursing home?
With a diagnosis of dementia or Alzheimer's, they sometimes, they're at different stages in the disease process, and with the different stages, a lot of times comes different behaviors. And if you have patients that are displaying some type of behaviors, such as some patients make repetitive noises, some patients will go to another patient in the facility and think that they're their mother and they follow them around. If you have that in the general population, somebody that does not understand the disease process and somebody that does not, has never been around somebody with that type of disease, they tend to get upset. It also, because the person with the disease they might not be able to state that this person's becoming upset with me, but they can tell by the body language that they're doing something that isn't considered normal. Right. It's just better to have them in their own unit where that is the norm and you don't have them integrated with people that do not understand the whole disease process and how to react to that. Mm-hmm. And how they're not doing behaviors because they want to do the behaviors. They can't help it, and they might be at the cognitive level of a 2-year-old and just not understand that.
Okay. Well, and that really explains, excuse me, that explains well how that benefits the other patients. I'm wondering what the specialized unit actually does for the dementia patients as well. From what I understand, it's more structured over there.
Mm-hmm. On the Homestead Unit, it's very structured. With saying that it's structured, it's also whatever is happening right in front of you, you have to roll with that, because although we do like structure, there are some times when patients are doing things that you just have to go along with it or you're going to increase behaviors. Mm-hmm. We have a general, we do person-centered care on our unit, which means that we do not have any housekeeping staff, we don't have any laundry staff, we don't have any activities, and we also do not have anybody that comes down from the dietary staff. Everything that is done for the residents on the Homestead Unit is done by the patients, or by the staff that are over there, the STNAs and the nurse. In a lot of facilities, the nurses, they do the med pass, they call the doctors, they do everything that's medical. On our unit, the nurses are wiping down the tables, they're doing activities with the residents, they are sweeping the carpet after the meals. It's like a family, and with that family concept and with not having this extra staff coming onto our unit, it decreases the behaviors, and it also lets the staff that are there know the patient very well, and they might even be able to tell that if a resident starts just tapping their hands on the table, that if you don't get some type of intervention activity and divert their attention to something else, that behavior right there is going to escalate to them walking up and down the hallways, trying to find their mother who's been passed, she's been gone for years, but we do not believe in reality orientation on our unit. Because if you would tell that patient, well, your mother's been gone for over 15 years, that's like the first time that you're telling that person, and you'll have the emotional breakdown that they just found out, and they might, why do that? It's better just to get into their world. Our unit is also beneficial for the patient. The staff that are there know the patient so well that they can almost anticipate what they need to do to keep the behaviors at a low level. Antipsychotics, anti-anxieties, any psychotropics are used very infrequently on my unit. I know a lot of facilities on behavior units, Ativan, if a patient gets agitated, they're giving them Ativan on a regular basis. We've had patients that have been over on the rehab unit, and because the rehab unit is very busy, there's people going on and off to therapy, there's whistles going off when people go through the door. It's just a very busy unit. The Alzheimer's patient does not, they just don't fit. It's not a good fit for them, and because of all those distractions going on, those people might come in and they might get Ativan, PRN, and they might get medicated because they do get agitated. Once they've moved to our unit, usually within a 2-week time period after they've adjusted, we no longer have to even use the PRN medications.
Well, I've really noticed that when I even walk through the doors onto the unit. Yeah, it's just tranquil, and it's a whole different pace than the rest of the facility here. Well, you know, I don't know if you know this or not, but my whole idea with my Abide With Me website is to provide an alternative for people who prefer to stay in their own homes and not end up in a nursing home. And I think that for a lot of diagnoses, that's a real possibility. You know, you get the right caregiver in there, and you know, a lot of people can live out their lives in the comfort of their own home. But I recently read a book that talks about, there were 2 sisters that did everything they could to keep their mom at home. She had early onset Alzheimer's, and they kept her home for years. And they found that they were using every last ounce of energy that they had just to take care of the basics, just to make sure their mom was safe, fed, bathed, you know, just the basic necessities of life, but they didn't really have any emotional reserves left to give her the mental stimulation that she needed or emotional, you know, input that she needed. And when they finally did place her in a facility, they were fortunate to find a specialized unit, you know, such as you have here at Hennis, and she actually improved. I mean, is that an unusual thing, or do you see that sometimes when somebody comes in that they actually gain some percentage points, you know, in their IQ just because of the program that you have here?
I do feel that we've seen that time and time again at the care center on the Homestead unit because we use what is called the Allen Cognitive Testing, and that is done on admission. That's done quarterly. It's a test that lets us determine what that person's their cognitive level is, and with that, they might be a 2.8, and they might function at the level of a 2 to 3-year-old.
Okay.
The staff know, and it's taught throughout the entire building, not just on the Alzheimer's unit, and our therapists are very involved in this, but that tells us that they're functioning at a 2 to 3-year-old cognitive level, but that does not mean by any means that we would not treat them like a child. We would not treat them like a 2 to 3-year-old. But with us having that knowledge, we would set them up with tasks and activities of daily living so that they could succeed. Where at home, they might tell their mother, here, go ahead and brush your teeth, and they get frustrated with their mother because they can't do that.
Right.
My staff would know that you can get them to do part of that task, and that is after you load the toothbrush with toothpaste.
Okay.
You might even have to do hand over hand, and that's where you would take, say you have a toothbrush in your hand, and they would take their hand and they would actually put it up and they would do a couple motions, and then they would say, brush your teeth, and then after you get them doing that, then they would be able to continue.
Yeah.
It's that long-term memory. You might have to stop them because in a half an hour, if you would leave them go, they might still be brushing their teeth because they don't have the cognition to say, okay, they're brushed, I need to stop.
Right.
But because all the staff here are trained, I do believe it's much easier to take care of them because our staff know that if they're at this level, this is how we need to gear their care. This is what we need to do to make them succeed. We've had a gentleman that he's passed on now, but he was in our facility, and the family actually, his wife lived just a couple blocks from here, and she would come and she would take him home. And this was towards the end. She would take him home and just to go sit on the porch or just to go and have dinner with a family. And he would actually look at her, and it was upsetting to her, but we would speak to her and tell her, this should provide you with comfort, because he would look at her towards the end of the evening and he would say, you need to take me home now. And as his wife, him being home, she'd bring him back crying, but I said, you need to feel good about this, that he feels so comfortable and he's so integrated with the structure and how we do things, that this is where he now is more comfortable. So I see that time and time again, that when they do come here, they might not be ambulating, they might not be eating well at home. Eating at home, it might be that because the family member, the caregiver, is just making just what she would for her family, and the person that has the dementia actually would do better with finger foods. And that's something that we here at the facility can determine, will they do better with finger foods, and that's determined a lot by what their Allen level is. And it seems simple, but if their appetite's good, they're eating the finger foods, then at home you wouldn't have to be worried about skin breakdown, you wouldn't have to be worried about them, developing the acute and then infection. And then when they lose weight, then you have to worry about their ambulation, and then they're a fall risk. And if they're here and we're looking at all that, and we also have the professionals, we have a dietitian, we have the chef, we work very well together and we're always communicating. So we have all those people, we have 20 people that are discussing the care that your loved one would receive versus just you and maybe a sibling that maybe might not have any background in the medical field, that you're doing the best you can, but not thinking of all the different things that really need to be thought about. It's all on an individual basis. Some people do better some people do better at home, but there is usually a time when is the time to bring them and let the people that specialize and have been trained to relieve some of that burden.
How would a family know that it might be time to look into a facility?
I believe that it would be time to look into a facility when the family members are becoming resentful because of the care that they have to provide. And it's not that you're angry with your mother or father, but the care that you're having to provide is so overwhelming that you have nothing to give to your family. You're doing it and you're going through the motions, but you're feeling very resentful. And a lot of times it comes to that point when the person with the dementia is acting out, and sometimes they get aggressive. And they're hitting, they're biting. A lot of family members can't deal with that because they can't separate, this is my mother, why is she doing this to me? They can't separate that. Yes, this is your mother, but because of this disease process, she's changed. She doesn't realize maybe when she's doing it that you are your daughter.
Right. What type of continuing involvement do you like to see from the family? Like you mentioned that the one lady who was able to take her husband home, for portions of a day, or maybe on the weekend for a few hours. I mean, do you welcome families to come in maybe at mealtime or?
If you would come over to our unit, especially in the evenings, there is usually between 5 and 8 family members, and sometimes that's more than just one family member. Sometimes that's 2 or 3, and they are usually having dinner with their loved one, the resident. We also have where there's activities in the evening. Different family members will come in, and then they'll take the loved one off of our unit, and they'll take them to a different part of the facility, and they'll engage in that activity. We encourage, I personally think that if somebody is coming into the facility and the resident is having a difficult time maybe adjusting, I will sit down with the family members and say, you know what, this might be a time where you need to take 2 weeks, call and check in and see if it's a good day, if it's a bad day, but it's a good time to just for 2 weeks, let us do our thing, let the resident adjust to the new environment, let them adjust to the new staff, because a lot of times if a family member comes in and visits, then it's, well, will you take me home? And then it'll start behaviors, and then it'll, you're leaving me here. How can you do this to me? I think it's at least 2 to 3 weeks to just not visit, still call, check in, but then after they've adjusted, we encourage family members to come in, every day if that's what they want to do. No, that's not something that some people can't come in every day, but even if they come in weekly, we have a resident right now that her loved one, her daughter lives in Columbus, and we know every Thursday she's going to be here from like 10 a.m. to get her hair done, and then she's going to be here till like 4 p.m. She's going to do lunch and dinner with her mom, and it's just what we do.
That's great. Yeah, I understand that it's always a wrenching decision, to place a loved one in a facility. But when you can find a place that is especially prepared to deal with whatever the problem is, in this case, the whole dementia unit, as you're explaining, specialized care, I think that takes a load off the family's mind to know that, this, maybe for this phase of your loved one's life, this may be the best thing to do. Well, I really thank you for your time, Beth. This was very informative. Thank you.